I'm going to talk about a very important issue here, which is regarding the selection of the donors in couple of situations. The important situations are, or the more common scenario in our clinical practice is a recipient comes to you with ESRD and the disease is ADPKD, and we need to find a suitable donor in the family. There is another situation where the donor is incidentally found to have multiple cysts, but he doesn't have anybody in the family uh, who is having ADPKD. So these are the common scenarios, and less common are, I'll take later in brief. Can we use ADPKD kidneys, known ADPKDs from a deceased donor or a brain dead donor, or how to deal with donors who have Bosniak 2 or 3 cysts. So first, talking about the common situation, historically, we all were using the criteria given by Revine, published in Lancet way back in 1994. That was based on purely on ultrasound findings and the age of the potential donor. Since then, we all know there have been refinements and advances in molecular tests involved and the better imaging options like CT and MRI. So I'll take you through that journey and then we'll see how we are today. So initially, we must know few basics and in ADPKD how the molecular mechanisms work. So there are basically two genes, the PKD1 in almost 75% cases and PKD2. This gene is located on chromosome 16 and the other one is on the chromosome 4. They are very important. PKD1 is supposed to have more aggressive nature. The recipients or the patient gets early disease, more aggressive disease, lands into ESRD earlier, whereas PKD2 is relatively moderate or less severe, and their expression may be little late with a less severe disease. By the time a patient with PKD2 reaches ESRD, it could be little later. This understanding has a lot of impact on the further management which we are going to talk about. And another important issue which we all should understand is that these are the two genes, as I stated earlier, and they work through the glycosylation, protein enfolding, and then they form polycystin 1 and 2 respectively. Now, these are the proteins which are actually responsible for the tuberogenesis. And if there is a deficiency or mutations in the gene and they are less, then one gets impaired tuberogenesis and the formation of cysts. I'm not going into detail how this all happens, but what we should know that these are the two proteins which are very important. Now, this slide is basically trying to show that besides PKD1 and 2, there are many other genes which work at glycosylation or protein folding in the endoplasmic reticulum and even in Golgi apparatus, and finally can give you the same kind of picture. Therefore, the molecular understanding, it is not only PKD1 and 2, but a lot of rare other genes, and that is how one should understand that why we need to do all this panel. Now there are about 60, but these are of course rare. Mostly, as I said, it will be PKD1 and 2. Again, this, and therefore, when I say genetic study, all this panel is to be tested, which is now easily available in India also. Now, these are the studies reconfirming my findings. One of them is from the Indian setting that one can have 4 genetic variants besides PKD1 and 2. Now, the second part is evolutions in imaging. Now, we all know that this was our historical classification. The individuals all enrolled in the study by Revine way back in 1990 and then published in Lancet in 94 had diagnostic criteria of PKD1, and then this classification was given. And these are the details from that paper. We did not go into all that. That is how it was established, and we were all following. In due course of time, it was realized that this classification is not working for two or three sets of populations, because we came to know about the PKD2 also. In this classification of Levine in 1994 was based on only PKD1, whereas we came to know about other genes and PKD2, etc. later. And these authors again published in 2009 saying that these criteria need to be redefined, and we'll go and see that little later. And these are all the statistics and the dynamics in the study, basically to say that if the PKD2 is there, then you need to increase the age of like 30, which I'll tell later, and below to 40 and below. And then they found that the results in 40 to 49, like there were a lot of sections for age, so they will be different. And therefore, they give a different modified classification, which we all. Then we all came to understand that ultrasound may miss a lot of cysts which are less than 1 millimeter. And so sensitivity and specificity goes down as the size of the cyst goes down below 1. And then came CT to our advantage, and where up to 5 millimeter cysts could be very well detected, and even smaller than that also with variable sensitivity. And so we are now using CT anyway for our DS angiogram, and therefore we can find more cysts on the ultrasound. This chart again shows that how the sensitivity of CT and the specificity it varies with size. Then came MRI, and now most of us in difficulty or in equivocal cases definitely need to resort to MRI. And they are even talking about, if you see the last sentence, if only simple cysts larger than 1 centimeter are considered, then these criteria can be applied to MR imaging. That means Revine was originally ultrasound based, but if you are doing it more than 1 centimeter, then you can apply the same criteria with MR. That's not the point. The point is that MR can detect cysts up to 0.9 millimeter, less than a millimeter, also can be detected by MR. And 3 millimeter, 5 millimeter, it has a very good sensitivity and specificity. And if you take the T2 weighted images, it helps a lot. If the individual is less than 30-year-old with a family history, confirmed PKD1 or 2, it has 100% sensitivity and specificity if you use a total of more than 10 cysts as a screening criteria. We'll see that in the clinical scenarios as we go further. This study is again about the more than 5 cysts, less than 5, you can exclude in a subgroup of 16 to 40. In a patient who has a relative with ADPKD, and if there are more than 10 on MRI, then that is sufficient for diagnosis, even if your genetic testing is, but it has to be supplemented with the genetic test also. Now, having understood the evolutions in the imaging, the molecular mechanisms, let us see the clinical scenarios quickly. A recipient has ADPKD, and we need to explore a donor in the family. A donor presents less than 40 years of age, he's say 29 or 30. How do we go about? He doesn't show any cyst on the ultrasound. So now our basic knowledge, whatever I was telling till now, will come into use here. So in this case, because ultrasound can miss many cysts, we need to do a CT or MRI. And as I said, go by the criteria given. If there are more than 10 cysts, definitely he has the ADPKD. And if it is equivocal, like 5 or 6, whatever, do the genetic study also. If genetic study is negative and on MRI there are less than 5 cysts, then you can safely proceed for donation in this. Now, in this scenario, the recipient has again ADPKD and there are cysts seen on the ultrasound. Now here, this is the historical criteria of Revine. We can follow it if there is a known PKD mutation in the family. And based on this, beyond 59 if there are more than 2 cysts, then definitely it's ADPKD and you can use this criteria in this particular setting only. If there are PKD2 mutation, Revine did not talk about PKD2. This came later. So if there are PKD2 mutations previously identified, then you see that the age range has been increased to 40 here. And if there are more than 3 cysts, either unilateral or bilateral, you exclude this donor. And if there are any equivocal cases, they do not fall into this. And if you think that there are the cysts less than 3 or less than 2 here on Revine criteria, if there are more than 2, okay, we don't need to do anything. If there are less than 2 here or less than 3 here, then we need to supplement with the genetic testing and MRI, as I was talking earlier. Now, in third scenario, there are multiple cysts in the donor, absolutely no family history. How do we go about it? If it is negative family history, do a good MRI, I would suggest. See if the kidneys are large and there are extrarenal features, reject. If kidneys are normal size, no extrarenal features, still do a genetic study, and then if it is negative, only then proceed for it. These are the papers below showing the kidney size and the use of genetic study. In this scenario, if the deceased donor known with ADPKD comes to you, you can actually, if the age of the recipient is also more and creatinine is normal as shown here in these criteria, donor is less than 50 years, you can use it. In this, if there are Bosniak 2 cysts, 2F is a little more dangerous, needs cautious dealing. 1 and 2 you can still follow. In 2F, you can follow him for 5 years and then he can be a good donor if there were no other donors in the family. Otherwise, you can remove this cyst and then take them for donation. Similarly, in 3, and it's only a Bosniak cyst, there is no ADPKD in the family. You can remove, excise the thing on the bench and then you can transplant. These are the same things now in the guidelines. Thank you very much for the patient list.
One short question to Dr. Aneesh Shrivastav, sir. Sir, am I audible to you, sir?
Yes, please go ahead.
Sir, a word about pre-transplant nephrectomies in APKD patients.
Well, there are only very few circumstances where you need to do pre-transplant nephrectomy. The first thing is, as we know, when the patient comes for assessment, we look at the tummy, abdomen, and look at whether the kidney, the lower pole is touching almost the anterior superior iliac spine, and then we try to palpate in a relaxed position whether there will be space or not. And what I do, I always see the ultrasound report also at the same time, the bulk, anterior-posterior bulk, length. Generally, what I have seen, if they are less than 20, easily you can put in the kidney. If they are more than 25 centimeters in size, and on clinical palpation also, because the tummies are different for different patients, for a thin, for a obese. So that is how I decide. So that is one indication, the size. Then, because if on the both sides the size is more, then you need to, of course, take out one kidney. If the size is less on the other side, more comfortable, just go on the other side. Then if there is a suspicion of malignancy or infection, as when the patients, you have to take the history. Sometimes they will have history of hematuria, something suspicious on the ultrasound. And equivocal, you do a MRI, CT, whatever, because he is ESRD patient. You can do MRI without gadolinium or CT even with contrast. So if there are suspicions, then also that also is an indication for taking out the kidney in ADP.
Sir, would you suggest both to be removed in same sitting, or you differ one after the another?
No, no. I'll just remove the one which is suspicious of either malignancy or infection or is likely to trouble, or one for making space. If both were very much large and you think that you may not be able to put the kidney in the iliac fossa. Only one. We don't need to remove both.